Okay, well, welcome to this lecture on Chapter 10, which is the last chapter that focuses on the calculation of doses. So between Chapter 7, 8, 9, and now 10, this is the culmination of all of our practice on calculating patient drug doses. And I love this chapter because it really has got four different kind of disparate topics a little bit, but it will apply some of our math and our calculations on calculating doses in very clinically oriented situations. So we're going to go out of our norm here a little bit and do the same sort of calculations, but put them more in the context like you would see them in clinical practice. And there's really, if you look through this lecture, there's four main areas. We're going to talk about heparin. As I warned you before, heparin is a common drug with units, so we'll focus on heparin. Then we'll do some unit conversions that are required when interpreting clinical laboratory values. Then we'll discuss equianalgesic dosing as it relates to using morphine milligram equivalents, or MMEs, a very important thing that's now done when converting between different opioid drugs, pain medicine. And then lastly, and very importantly, we'll start to address the issues that relate to kidney failure, kidney impairment, and having to adjust drug doses based off of kidney function. And to do that, you calculate what's called a creatinine clearance. So again, some very important topics in pharmacy, and we'll just kind of introduce some of these topics, but I think it will apply some of what we've been learning in terms of calculations in a much more clinical setting. So with that, let's get started. The first topic we're going to discuss is heparin, and I've mentioned it before. Heparin is an anticoagulant, and basically what that means is it is a blood thinner, and I'll talk a little bit more about that here in a second. So just with that, know that the reason we're talking about it is that the Institute for Safe Medical Practices, abbreviated ISMP, has classified this drug as a high alert drug. And there are other high alert drugs, but certainly what it means to be a high alert drug is that all practitioners, pharmacists, nurses, physicians, bear special attention to this drug because it has a history of causing significant patient harm. So it's like a red flag. This drug is something that you need to stop and take extra special care to ensure that you're giving the right dose with. And the reason for that, and I won't belabor all of these timelines, but if you look over here from 2006 and to 2010, there were several very high profile examples of patients being harmed or killed by the misuse of heparin. Now, I remember kind of the big thing was 2007 with Dennis Quaid, a famous movie actor. His two infant girls were killed due to overdoses with heparin. So that brought, certainly a lot of media attention to it, but not the only. I mean, that was one case out of many. So there's been a long history of patients being injured due to accidental misdosing of heparin. So it's important for me to understand, for me to help you understand why. Why is heparin such a problem? It's a blood thinner. The reason it's a problem is that it can be used as a blood thinner for multiple reasons. And the doses you would use are different for each of those reasons. So let's start with its use as an anticoagulant or a blood thinner. So I know this says, if you look on the screen, it says that it's indicated for the use of for prophylaxis, which means the prevention of, or the treatment of thromboembolic disorders. And these basically means blood clots. So think about a blood clot in the lung is what we call a pulmonary embolism. A blood clot in the leg would be a DVT, or a deep vein thrombosis. These are both really bad things. That blood clot can cause injury or death, possibly, to this tissues. So what would you want to do with a blood clot? First you want to do is keep the clot from getting any bigger, and then also slowly start to dissolve the clot. To do that, you would use a blood thinner like heparin. The dose that you would use to prevent a blood clot, that means the prophylaxis dose of heparin, is much lower than the dose you would need to actually treat somebody who's already developed the clot, that you need to try to prevent from getting worse and to start to reduce its size. So very different doses. Doses differing from like 10,000 units versus 5,000 units. That's a big difference, right? Now, here's where it gets even worse. That heparin is also commonly used to neither treat or prevent a clot disorder, but simply to prevent a blood clot from occurring within a IV administration set. So a Hep lock solution prevents the devices. So to be able to administer an IV, you have to have an IV line set kind of into somebody's vein. Well, what happens over time is that blood can clot in those devices, and then you can't administer any IVs. So what nurses typically do is flush those IV lines with just enough heparin to keep a clot from forming within those plastic tubes. You're not treating anything. They don't have a clot. You're not preventing clots. You're not treating clots. In the patient, you're trying to prevent a clot in this IV tubing. And to do that, you need a very small amount. You only need maybe 100 units. So think of this, 100 units to keep what we call flush the IV lines, to keep the IV lines from clotting, 5,000 units to maybe prevent a clot from forming in a patient, or 10,000 units to try to treat a clot that needs to be reduced. So giving the wrong dose to the wrong patient can be really problematic. And the biggest problems have occurred when somebody has only needed the 100 units of heparin to keep their IV line open, and they end up getting 5,000 units or 10,000 units. So what happens is their blood gets very thin, and they start to bleed out, and it creates all sorts of potential problems. So due to heparin's multiple uses for multiple reasons has been why so many patients have been accidentally exposed to the incorrect dose. So let's try to use it correctly. So let's show you how, in a clinical sense, heparin would be used to help manage a patient. So let's read the question. It says, a blood sample is taken from a 113-pound patient 6 hours after heparin therapy is initiated and shows an APTT of 24 seconds. So let's stop there. A lot of information there. First of all, heparin, we said, is a blood thinner. So you're going to determine the degree of its effectiveness. That is, how much heparin you need will depend on how thin you need to make the blood. The way you measure the thinness of the blood for heparin is measuring a lab value called activated partial thromboplastin time. So APTT is the lab value, and it's measured in seconds. The longer the value, that is, the greater the number in seconds, the longer it takes for the blood to coagulate. So you're basically seeing how long it takes for the blood to coagulate. A short number, or a small number rather, would be a relatively fast coagulation. It's not a very anticoagulated blood sample. But a larger number, the longer the value in seconds, the longer it takes to coagulate, the more anticoagulated the patient is. And again, the trick is we want it to be long enough so that we don't get the coagulation and the blood clot, but we don't want it so large and so long to coagulate that the patient could bleed out. So in this case, we're going to have to interpret here in a minute what a value of 24 seconds means. But that's an important value that tells you how effective the previous dose or our current heparin therapy, this patient has already been on heparin for a while, that'll tell us how strong of the therapy is. Okay? Now, going back to the question, it says, standard heparin IV comes as a pre-mixed solution that has a concentration of 100 units per ml. So, what we want to do is A, calculate a bolus dose volume, and B, the corresponding infusion administration rate in milliliters per hour according to the heparin dosing protocol shown here on the right. So essentially, given the information we have, we want to correctly use the heparin dosing protocol. So let's look at the protocol, okay? This patient has already gotten an initial heparin dose. So the first line where it says bolus dose, and then below that a couple of lines where it says continuous infusion rate, this patient has already been started on that. So the question really is, based off of where we're at with the current dose having caused an APTT of 24 seconds, now how do we need to adjust the dose? So this is a question about adjusting the dose. So if we look under the protocol where it says for these APTT values, do these things, all right? And you'll notice here, if you just kind of look going down from top to bottom, the lower the numbers we said, the less the anticoagulation, the larger the numbers, the greater the anticoagulation. So if you look at the dosing in response to the different APTT values, at the lower values, you need more heparin, but at the larger values, going from 46 to 70, where there's no change needed, to 71 to 90, you're actually decreasing the rate. To greater than 90, you're actually holding and not administering the dose because, again, you've got too much heparin on board. The patient is too anticoagulated. So the longer the value or the larger the value in seconds, the less heparin you're going to want. So what do we need to interpret at about 24 seconds, though? 24 seconds would be in the less than 35 second category. So in that case, we would go to the right of the less than 35 seconds. And what it tells us to do is to bolus again with another 80 units per kilogram. And a bolus means an initial single dose. And then we're going to increase the continuous infusion rate by 4 units per kilogram per hour. So that's what this question is really asking us to do for this 113 patient. Based off of their results, we need to give them an additional 80 units per kilogram bolus and increase their continuous infusion by 4 units per kilogram per hour. So therein lies all of our calculations that we're going to have to do. All right, so let's start on those calculations. The additional thing that I'll show you here is remind you the actual product we will be using as our source of heparin is a bag that contains 25,000 units of heparin in 250 mils of 0.45% sodium chloride. So again, if you take 25,000 divided by 250 mils, and you can see on parentheses on that image to the right, we really are using a bag that has a concentration of 100 USP units of heparin per milliliter. That's the 100 units per mil. I'll also point out while I'm here, you'll notice in the box, it says high alert right there on the label. Remember how we said that on all of our commercial products, we want any practitioner using heparin to be reminded that this is a high alert drug and to take special care with their dosing. Okay, now let's start. From the protocol, we know that we need to first give them another bolus dose. So that's where we'll first start our calculations. Let's calculate the bolus dose. To do that, we'll start with their weight, which we were given as 113 pounds. We'll take 113 pounds and convert it to kilograms by multiplying by 1 kilogram on top over 2.2 pounds. Pounds cancel. We're now in kilograms. The protocol told us that the bolus dose was 80 units per kilogram. So we'll multiply that by 80 units over 1 kilogram so that the units of kilogram cancel, and we're now in units. But remember, we need to calculate the volume. So we're going to multiply units by the concentration, expressed as for every 1 milliliter on top, there would contain 100 units, and the 100 units is on the bottom, so that the units of units cancel, and our final units would be in milliliters. So if you do that math all the way across, starting with 113 and working your way across, the value you should get in the end is 41, and the remaining units was milliliters. So we would need to give 41 milliliters of our 100 unit per mil solution to be able to give this patient the bolus dose that they require. So that finishes the bolus dose. Next, let's talk about the continuous infusion. So again, it's still going to be weight-based. So we'll start with our weight again at 113 pounds. And now we're going to multiply that times the conversion of 1 kilogram per 2.2 pounds. So pounds cancel. And what we need to do now is, as a reminder, and I'll flip back here because it was kind of confusing. I skipped by that a little bit. The continuous infusion rate on top there, you'll notice that they were already started on, was 18 units per kilogram per hour. So that's what they're on currently. Look down below where it says to change if less than 35 seconds, it said to increase the rate by 4 units. So from where we're starting at, which was 18 units per kilogram per hour, to adjust it based off of our result of 24 seconds for our APTT, we need to increase that rate by 4. So hopefully that makes sense then, that going back to the bottom for letter B, we're going to take our weight 113 times 1 kilogram over 2.2 pounds. Now we're in kilograms. Now we multiply it by, the new rate is going to be the 18 plus 4. So essentially we're going to multiply it by 22 units per kilogram per hour. So the units of kilogram now cancel and we're in units per hour. And then we want to convert that to a volume. So we'll again multiply it by the same solution, which has in every 1 milliliter, it has 100 units. So now the units of units cancel. And if we do that math all the way across, this new accelerated infusion rate would be at 11.3 milliliters per hour. And so that's the answer to this question. We would give, based off of the results of 24 seconds, we would give them an additional bolus of 41 milliliters and can follow that up with a continuous infusion of that same solution, but at a new, faster rate of 11.3 milliliters per hour. So hopefully you kind of see this is kind of the sample calculations you would do clinically for a patient who is needing to be on heparin to treat some sort of thromboembolic disease like a pulmonary embolism or maybe a deep vein thrombosis. All right, the next section of this lecture, if you will, has to do with clinical laboratory test. And I won't say interpretation. You're going to have entire courses on clinical chemistry and learning how to interpret lab values to adjust patient drug therapy, if you will. But what we wanted to cover in this course, in terms of a calculations course, is simply this, is that the use of various laboratory values are extremely important in helping manage patient care and knowing whether to increase drug therapy or to understand the impact of drug therapy on patients' conditions. We definitely look at clinical laboratory values. And simply a clinical laboratory value, keep in mind, is simply when you send off and analyze a biologic fluid, a sample. So whether it could be blood, urine, or gosh forbid anything else. They'll take that biologic sample, they'll send it to the clinical laboratory, and that laboratory will analyze it for some component and then give you back some sort of a numeric result. The problem is, and this is a legitimate problem, is that the units that they return that value in can vary. And a big problem is even looking at different treatment guidelines from Europe versus American, we use different laboratory values. And so, for example, instead of SI units or the international system units, US commonly, and maybe some of your literature that you use to evaluate these values may have different units for the same value. So just as an example, cholesterol. We're going to use cholesterol as our example for this calculation. A normal value or a patient's value that you might get from a laboratory value would be 180 milligrams per deciliter. Okay. However, it could also come back from that same laboratory expressed as 4.65 millimoles per liter, or even as millimolar, because we already talked about how millimoles per liter is millimolar. So you might have a value of 4.65 versus a value of 180. It's the same thing, but it's different units. And so it's very difficult to compare one laboratory value report to maybe a treatment guideline that says to do something if their values are above 4.65 when you're looking at a value of 180 milligrams per deciliter. So you must become very skilled at simply being able to take whatever laboratory value you have and whatever units they report to you and convert them to whatever units you need to then use to interpret that value. All right? Enough said. And it's not difficult, but it's something you've got to do and do carefully and do commonly, I would say. It's not uncommon to have to convert units, especially between European values to American values. Oftentimes, we're going to have to re-express things, especially like glucose and cholesterol. You do it quite a bit. All right, so let's get to the question. The question is, total serum cholesterol, which we're going to say has a molecular weight of 387, is composed of, really more than this, but at a minimum, two components. Low-density lipoproteins, which are abbreviated LDL-C, and the C is for cholesterol, and HDL, which stands for high-density lipoprotein cholesterol. Okay, so if we think of total cholesterol in a very simplified way, you could say it's composed mainly of LDLs, low-density lipoproteins, and HDLs, high-density lipoproteins. If a patient has an HDL-C value or level of 65 milligrams per deciliter and a total cholesterol value of 5.43 millimoles per liter, what is the LDL-C value in milligrams per deciliter? Wow, this is kind of all over the place. So where do we start with all of this? Well, let's start with the question here, and again, I've given some multiple choice values for this just to kind of see what you end up with. But let's do this. We've got two different sets of units. We've got milligrams per deciliter, we've got millimoles per liter. And since the final answer wants to be in milligrams per deciliter, let's start by converting our total cholesterol from the units of 5.43 millimoles per liter to the corresponding value in milligrams per deciliter, so we can mix it with our other values for HDL. Okay, so that's our first calculation. So let's set up what we have, which we have is 5.43 millimoles on top per 1 liter on the bottom. And we essentially have to go from millimoles to milligrams, and we have to go from liters to deciliters. So this is a two-step process. You could do either one first or second, it doesn't matter. What I've chosen to do is to convert first millimoles to milligrams. And remember, we said that the conversion for any molecule is from its weight to the number of molecules in moles is by its formula weight. And we could do grams per mole, or we can do milligrams per millimole. And since we're in millimoles, we set this up by multiplying by the fact that we said the formula weight for total cholesterol was 387, and we put milligrams next to that units per then 1 millimole. Remember, 1 millimole would equal the formula weight in milligrams. We set this up so that the units of millimole cancel, and now we'll be in units of milligram, but per liter. So we still have to get rid of the liter. Okay, so the next conversion would be to multiply for the fact that in 1 liter on top, there are 10 deciliters. Therefore, the units of liters cancel, and you can see your final, if you do the multiplication all the way across, your final units would be in milligrams and per deciliter. And if you do that math, 5.43 times 387 divided by 10, you get 210. So essentially we're saying 5.43 millimoles per liter of total cholesterol is the same as 210 milligrams per deciliter. Well, that's not our final answer, but we had to have that answer because what it's asking for is the concentration of LDL. Okay? To figure out the LDL, we have to use the fact that we were told that total cholesterol is equal to LDL plus HDL. And of that formula now, we have 2 out of those 3 values. So let's rearrange that formula and solve for LDL. So simply to do that, we have to subtract HDLC from both sides. So now we can say that total cholesterol minus HDL is equal to LDL. We have numbers for those two, so let's substitute our numbers in. We know that our total cholesterol is 210 milligrams per deciliter. And from that, we can subtract our value for HDL, which was 65 milligrams per deciliter. But this is what's important. Make sure you understand this. The only reason you can subtract those numbers is that they are in the same units. They are both in milligrams per deciliter. That's why we had to convert our total cholesterol to milligrams per deciliter so it would match the HDL value. Okay? So that's why this works. So essentially then 210 minus 65 equals 145, and the units are in milligrams per deciliter. So our final answer is 145 milligrams per deciliter, and that represents the concentration of the LDL-C, which, along with the other component, HDL, which was 65 milligrams per deciliter, the two combined, is what makes up the total for the total cholesterol and was why there is 210 milligrams per deciliter of the total cholesterol. So that ends this question, and really the big take-home point is you need to become, when interpreting clinical laboratory values, you have to be very cognizant of their units that they're reported in and to be able to convert units when necessary. All right, let's start the next section of this lecture, which is about equianalgesic dosing charts. And again, a very important skill for pharmacists to have. I show on the lower right-hand side a publication by ASHP, a whole book about opioid conversion calculations and how important it is to be able to effectively dose these drugs, especially in a hospital setting where there is more acutely ill patients with pain management needs. So this is definitely a skill pharmacists have, and it is well beyond the intent of this lecture is to actually talk about pain management for patients. What I want to focus on are some of the calculation skills, the numeric skills you have to be able to do this important skill. So very briefly, this all relates to the fact that there are multiple narcotic analgesics, and these drugs are often termed opioid analgesics. And the reason we call them opioids is because they are chemically related. And if you look down on the table just briefly at the very top, you'll see we really stemmed from the primary one we had to begin with was morphine. All of these were chemically derived from experimentations from the morphine molecule. So even when we use this table, our gold standard that we're going to compare things back to is to morphine. Now, keep in mind, some of the drugs we've derived from morphine, such as hydromorphone, oxycodone, and hydrocodone, are actually more potent than morphine. whereas other derivatives like codeine and meperidine are still analgesics, but they're not as potent as morphine. So some are more potent, some are less potent, but they're all chemically related to morphine. Other things to understand to put why we would do some of these calculations into context is oftentimes with patients with chronic pain needs, not acute needs like a broken or a sprained ankle. Those will heal, and therefore their use of pain medicines is only short term. These calculations tend to be more for patients who have cancer pain, who have maybe chronic conditions, back pain, other muscular and neuromuscular disorders that won't heal in any time soon. So they have to be and manage their pain chronically over time. The reason this is an issue is the issue with tolerance. People become tolerant to their pain medications, to their opioid drugs, meaning they have to continually, over time, weeks, months, years, increase their dose and take more drug and more drug and more drug to be able to experience the same pain relief or the same analgesic. That can create issues because over time you may at such a high dose that you're starting to get adverse reactions, side effects. There may be issues with taking the drug at that level to get that pain relief, and therefore it might necessitate needing to switch from one analgesic to a different analgesic. Okay. The other thing to be aware of when you do switch from a drug that you have become tolerant to over time to a different opioid, and even though it's still an opioid, it's still in the same chemical class, you're oftentimes not cross-tolerance. There isn't cross-tolerance to that new drug. Therefore, we have to be very careful and reduce the dose back down, or you could overdose somebody. Okay, so taking all of these things into consideration, we'll apply that here in a specific example in a minute. But let's look at this table because this is an important table to understand a couple of things. What it gives you on top is the values for morphine, and it gives you a standard dose of morphine for both oral in one column, then IV, and then the last column, PR, stands for rectally or per rectum, so those are the rectal suppository doses. Let's just look at the oral dose. For this lecture, we're just going to focus on the oral dose. And what we can see on this table is that for a 30 milligram dose of morphine, we can see an equivalent dose of the other various opioids. So that's what I remember how I said hydromorphone, oxycodone, and hydrocodone were more potent. Well, certainly hydromorphone and oxycodone are more potent than morphine because equivalent to 30 milligrams of morphine, you only need 7.5 milligrams of hydromorphone, or you only need 20 milligrams of oxycodone produce the same analgesic effect as 30 milligrams of morphine. Hydrocodone, on the other side, is equally as potent as morphine. So 30 milligrams of hydrocodone is equivalent to 30 milligrams of morphine. On the other hand, something like codeine is much less potent than morphine. You have to have almost 200 milligrams. You do have to have 200 milligrams of codeine to equal only 30 milligrams of morphine. So it's much less potent. The other way that you can use this table, and we're going to apply in our calculations here, is that now we know the doses of the drugs that relate back to 30 milligrams of morphine, but we can also then relate the different opioids to other opioids. So for example, what is the relationship between hydromorphone and oxycodone? Well, since 7.5 milligrams of hydromorphone is equivalent to 30 milligrams of morphine, and 20 milligrams of oxycodone is equivalent to 30 milligrams of morphine, that must mean that 7.5 milligrams of hydromorphone is equivalent to 20 milligrams of oxycodone. Hopefully you can kind of see that. But using this table and relating everything back to morphine can allow us not only to compare opioids to morphine, but we can compare opioids to other opioids. And let's do that in a sample question here in a second. But before we actually do that sample question, I want to I'll try to go through this briefly, go through some important process. How would you actually use that table? You're going to step one will be to take the person's opioid current use and add it all up. It doesn't matter how many times per day or 2 tablets or 1 tablet or whether it's extended release or immediate release, just add up their total daily dose of that opioid. Then once you have that, step 2 is to use the table we just discussed to be able to convert it to a different opioid. And we'll do that here in a minute. But this is what's important. Step 3 talks about the fact, as I mentioned, their current dose on one opioid as you switch to a different opioid won't take into account the tolerance that is developed over time. So we often have to back down the dose on the new opioid to take that cross-tolerance into account. So we often reduce the dose by 30 to 50%. And remember, that was their daily dose. So step 4 is to, based on the new drug's dosing schedule, maybe it's twice a day, whereas the old drug was 3 times a day. Whatever it is, we take the total daily dose divided by the new drug's dosing schedule to be able to calculate the actual dosing schedule based on the frequency. All right, so let's apply all that. Let's go ahead and do it to a specific example. So the question reads, a 48-year-old male with chronic low back pain due to degenerative disc disease has been gradually increasing their dose until they are now taking 2 hydrocodone with acetaminophen 7.5/300 milligram tablets, and they're taking those 2 tablets at a time every 4 hours, and have been doing so for the past 2 months. However, due to this patient's continued alcohol use, his prescriber is worried about continuing to give acetaminophen. Therefore, the prescriber wants you to recommend an equianalgesic dose of OxyContin, which is a brand name of an extended-release oxycodone drug that has no acetaminophen in it and is actually dosed just every 12 hours. So we have a lot of information. We have information about what the patient has been taking with their hydrocodone. We also have information about what the prescriber wants them to switch to, which is extended-release oxycodone. Okay, and then we have this table of information that we have here in the middle. Okay, so while we're looking at the table right now, we are going to, in a minute here, going to need to relate a dose of hydrocodone to a dose of oxycodone. So looking at this table, we conclude that 20 milligrams of oxycodone would be equianalgesic with 30 milligrams of hydrocodone, because both of those values are equianalgesic to 30 milligrams of morphine. So that's the relationship. 20 milligrams of oxycodone produces the same analgesic as 30 milligrams of hydrocodone. From that table, we can get that information, and we're going to use that here in this question. So step 1, it says to add up all of the current opioid dose for this patient. So to do this, we'll start with the fact that the patient was taking 2 tablets for every dose. Every time they took a dose, they took 2 tablets. Multiply that by the fact that the tablet had 7.5 milligrams of hydrocodone per tablet. Now we can disregard the acetaminophen. What we're doing is switching from one opioid to the other, and so we don't have to factor in the acetaminophen. Now we know how much hydrocodone we have per dose. We're going to multiply that by the fact that they were taking 1 dose every 4 hours. So now the units of dose cancel, and we're in milligrams of hydrocodone per hour. Lastly, this was the amount they were taking for 24 hours per day. So if we multiply that by 24 hours, hours cancel, and we will have the milligrams of hydrocodone this patient was taking per day. So doing the math from left to right all the way over, you would get 90 milligrams, and the units are hydrocodone per day. So that should be pretty straightforward. That's what the patient is currently taking of hydrocodone on a daily basis. The next step was to use the information we talked about previously on that previous table to convert from milligrams of hydrocodone to milligrams of oxycodone. So we take 90 milligrams of hydrocodone, multiply it by the fact that we saw on that table that 20 milligrams of oxycodone was equianalgesic to 30 milligrams of hydrocodone. And we put the hydrocodone on the bottom, so the units of milligrams hydrocodone cancel. And when we do that, the math, 90 times 20 divided by 30, you should get a numeric value of 60, and our units are in milligrams of oxycodone. Now, a big mistake would be to go ahead and just try to dose at that level. But remember, step 3, which is really important, says that, okay, this new opioid has to be brought back down because of the potential for cross tolerance. Okay, so let's reduce that dose by 30%. And again, clinically, this is where clinically it can be done anywhere from 30 to 50%. For this question, we'll just choose 30%. So let's take the dose we calculated, which was 60 milligrams of oxycodone, and multiply it by 0.7. So we only want 70% of that dose, which represents a 30% reduction. So 60 milligrams times 0.7, or 70%, would give us 42 milligrams. So the total daily dose of oxycodone for this patient should be, to start them off, at 42 milligrams per day. But now we have to take into account how the OxyContin brand of oxycodone is administered, and it's dosed every 12 hours, which means in one day there would be 2 doses. So let's take 42 milligrams of oxycodone per day times, in one day, we're going to administer 2 doses. So 42 milligrams divided by 2 gives us 21 milligram per dose. Now, that's a very precise number based off our calculations, but we need to round it to a dose we can actually administer in terms of the strengths of tablets that are available. So, since it only comes in 20 milligrams and 30 milligrams, what's important to remember too is you always round down. Remember how we're being conservative about making sure we don't overdose because of the lack of tolerance. So we would round 21 down to 20 and give this final dose for this patient would be to give them a 20 milligram dose and to do that every 12 hours. And if you think about that, 20 milligrams every 12 hours is 40 milligrams a day. That's close to the 42 milligrams of oxycodone we calculated based off of the cross tolerance to get from the 60 milligrams, which is a direct conversion from the hydrocodone. So anyways, hopefully you can kind of follow some of what we were doing here, and the actual remembering the steps in this process at this point is less important than to understand some of the math skills that are required for being able to calculate total daily doses, to be able to use conversion factors to go from one opioid to a different opioid, and then finishing it off. So I think it's a very interesting example of a common type of calculation that pharmacists are certainly doing much more of now due to the problems we're having with things like the opioid crisis. All right. Now we're in kind of a transition phase now from topics. We're almost to our last topic, which is a really important one about estimating kidney function or renal function using creatinine clearance calculations. One of the important factors that you use in these creatinine clearance formulas is body weight, and using the correct body weight is really important to get a reasonable estimate of somebody's kidney function. So we need to talk about a couple of formulas used as it relates to trying to identify the most appropriate body weight to use in those formulas. So let's define the term. First term we're going to talk about is actual body weight, and that's abbreviated ABW. Now, like it sounds, actual body weight is the actual weight measured on the patient. You put the patient on the scale, and the scale says they weigh this amount. All right? That's obvious. But just think about it for a second. Just realize what that weight represents is the weight of everything. Both adipose tissue, fat, and muscle, and bone, and organs. All right? That's everything. The reason that's important is that not all drugs go into all tissues. So sometimes it doesn't represent the most accurate weight in relation to where a drug might actually be. So just keep that in mind. Actual body weight, ABW, is just the actual weight the person stands on the scale. Every single part of them. Okay? Now let's separate that to ideal body weight. An ideal body weight is abbreviated IBW. And what it does, it is a better estimate of the weight in which some drugs, particularly polar drugs that are not well distributed into fats. So you don't want to base a dose of a drug on a weight that includes weight where the drug isn't going to go, because then you'll have extra drug, and that extra drug won't be dispersed everywhere. It'll be more concentrated into the muscle or the organs and possibly give you too much drug. So in this case, an ideal body weight essentially takes a core weight and then adds additional weight based off of height. So the formulas are, and the other thing I would just tell you with ideal body weights you have to be very careful with is that it is slightly different for females than in males, primarily only in the starting weight. So looking at the formulas you can see here, the ideal body weight for a female starts with 45.5 kilograms, and you add to that 2.3 times the number of inches over 5 feet. So if somebody is 5'6", you would take 6 inches, the number of inches over 5 feet, 6 inches, times 2.3, and add that number numerically to 45.5 in kilograms, and that would be the correct weight for ideal body weight, IBW, for a female. For a male, it works exactly the same, except for your starting weight is 50 kilograms. So you take 50 kilograms and add to it 2.3 times each inch over 5 feet. All right. So that's how you calculate ideal body weight. The only trick is make sure you use the correct formula by gender, either female or male, and the correct starting number. But it's a pretty easy formula to kind of memorize and remember. And keep in mind, this is not used for all drugs, but it is an important way to use for drugs that don't distribute into fat. Therefore, we can estimate somebody's body weight without much fat. And these, if you do go ahead and try this, calculate your own ideal body weight, you might notice for a lot of us that seems to be a lot less than my actual body weight. It really does estimate a weight without almost any adipose tissue or any fat tissue. So that gives us to our third body weight, in the fact that sometimes an ideal body weight is a very low body weight and not even close to what most people weigh to some extent. So is there somewhere to get in the middle, that where we don't have a bunch of extra adipose tissue, and especially if somebody is obese, then we don't want to use all of that obese extra body fat or adipose tissue and assume that that is muscle mass or organ mass or bone mass. We want to somehow cut the distance between this really low ideal body weight and maybe their potentially obese actual body weight. And that's where the adjusted body weight comes in. Now, keep in mind this is abbreviated AJBW. Don't get confused with ABW. ABW said was actual body weight. AJBW stands for adjusted body weight. And it is a body weight we typically reserve for people who are obese. And therefore, since they have so much extra adipose tissue, this might actually come up with a more reasonable, leaner body weight. So it isn't as lean as ideal, which has no adipose tissue, but it is certainly not going to overestimate had we used their actual body weight. Okay? So, and really, if you look down at the formula, it's basically starting with their ideal body weight. So you calculate the ideal body weight just like you did, we talked about before, for just regular IBW. But what you're going to do for the adjusted body weight is you're going to take their ideal body weight and then add to it a factor. And the factor is simply this: take their actual body weight and subtract their ideal body weight. So find the difference. And then we're going to take some proportion of that difference. So the amount of fat or the amount of weight that we're cutting off, going from actual to ideal, let's add part of that back in. Okay? And for renal clearance calculations, most often, and it's not universal, but most often, it's about 40%. Or we take 0.4 times the difference. So 40% of the difference is added back to the ideal body weight to give you a 40% increase in the ideal body weight to that extent. All right. That's what we'll do here in a minute for our creatinine clearance calculations. But keep in mind, we will also bring back this same formula when we do calculations for total parenteral nutrition, or TPN. When we're calculating somebody's nutritional needs, we also need to maybe potentially use this adjusted body weight. At that point, though, the adjustment factor is often reduced down to 0.25. So, and what's important now, just realize that an adjusted body weight starts with the ideal body weight and adds some fraction of the difference between the ideal and the actual back to the ideal. So the ideal adjusted body weights will always be higher than ideal body weight, but they're also always lower than actual body weight. It's an attempt to find some middle ground between those two. Okay? So, and for these calculations going forward, we will say take the ideal body weight, subtract the difference between actual and ideal, and take 40% of that back to and add it to the ideal body weight. That's our formula for renal clearance and using adjusted body weight. Okay? So 3 body weights: actual body weight, ideal body weight, and adjusted body weight. Okay? Now, there is, and the last bullet point here is important, there is some controversy. There is not one golden rule for when you always use actual or always use ideal or always use adjusted. There are various recommendations. There are clinical protocols. I'm going to give you some suggestions, and these suggestions that we use here in lab or in this class relate to what we see as the most common clinical practice, but there's no universal clinical practice when it comes to exactly which weight to use in some of these creatinine clearance formulas. And that makes it a little bit more difficult for students, and you may see some different recommendations on rotations or at different work sites, but in general, the process we're going to go through is similar. It's just some of the specifics about, like, for example, which weight to use might vary a little bit by your clinical rotation site. So with that, let's practice on doing these calculations and seeing how these weights can vary. So the question here says, what is the ideal body weight, IBW, and the adjusted body weight, AJBW, and we're going to use 0.4 as the correction factor, for both a woman and a man, so both genders, both of whom weigh the same amount, so both the man and the woman weigh 200 pounds, that's their ABW, actual body weight, and both stand 5 feet 8 inches tall. All right. So let's go ahead and do that. So I show you my calculations on the left for female and on the right for male, and we'll go through both genders, but let's just do one weight at a time. So on the left-hand side for female, if we kind of take their actual body weight and let's convert it to kilograms so we can compare our results all in kilograms. So for the female, we take their actual body weight. They said it was 200 pounds. To convert 200 pounds to kilograms, we multiply it by the fact that there is, for 1 kilogram, there are 2.2 pounds. So again, the pounds units cancel, and so 200 divided by 2.2 is equal to 91 kilograms. And you can see that on the left, on the top, for female. Now, if you look on the right for male, understand, it's the same number. There are no gender differences when we just convert a weight in pounds to a weight in kilograms. So both of these individuals, both the female and the male who weigh 200 pounds, both weigh 91 kilograms. There's no difference in their actual body weight, whether it's in pounds or kilograms. Okay? Now, you'll see that won't hold true as we go forward. Let's go back to the left for the female, and let's calculate her ideal body weight. Remember, the formula is different now for ideal between females and males, so we do need to use the correct female formula. So for that, we would do 45.5 kilograms plus 2.3 times each inch over 5 feet. Since this patient stands 5 feet 8 inches tall, let's take 2.3 times 8 and add that to the 45.5, and we can see then for the female, her ideal body weight is 63.9 kilograms. Now, even at this point, if we just stop, remember how I warned you about how an ideal body weight seems awful low for a lot of people? Well, compare the ideal body weight of 63.9 kilograms to her actual body weight, which was 91 kilograms. That's a big difference. So an ideal body weight, when you calculate it, really does estimate a weight with almost no adipose tissue. It is sometimes a kind of scarily low number for a lot of people to consider. Let's do the same thing for the man now. So go over to the right-hand side, and for the male, we'll calculate the ideal body weight, and we'll start with 50 kilograms plus 2.3 times each inch over 5 feet. So we'll take 2.3 times 8, add that to 50, and we can see that his ideal body weight is 68.4. So it should be just a little bit obvious from the formula itself. A male's ideal body weight will be slightly higher, about 4.5 kilograms higher than a female's. But other than that, they're very similar in terms of the way that the weights are calculated. And in both situations, a significant reduction compared to most people's actual body weight. Okay. Now let's look at the difference between, we've looked at actual body weight in kilograms and ideal body weight in kilograms, and so let's calculate the adjusted and see how it comes up with a number a little bit more in the middle. So going on the left-hand side again for the female, we'll do the adjusted body weight formula by taking their ideal body weight that we calculated. And for the female, we said her ideal body weight was 63.9 kilograms. To that, we're going to add. And first, we've got to find the difference between their actual, which was 91 for her, and her ideal, which was 63.9. And the difference we're going to multiply by 0.4. So on the second step down, you can see the difference between 91 and 63.9 is 27.1. That was the difference between those two. So when we multiply 27.1 by the 0.4, we can see what we're going to add to the ideal body weight is 10.8 kilograms. So when we do that and add that to the ideal body weight, we can see that her final adjusted body weight is 74.7 kilograms. All right. And just quickly to go through the male patient, same process, though we start with 68.4 for him, and to that we're going to add the difference between 91 and 68.4. That difference is 22.6. We multiply 22.6 times 0.4, and that equals 9 kilograms. So when we add that to his original ideal body weight, his final adjusted body weight is 77.4 kilograms. Okay, so if we just finish off with the male, let's just compare those numbers. We said the male's actual body weight was 91. The ideal body weight, IBW, was 68.4. And his adjusted body weight is 77.4. So hopefully you can see all we're trying to do with these weights is say, okay, if this guy, everything on him, including all the fat and everything else, makes him weigh 91 kilograms. If we took off all possible sources of fat, he'd only be 68.4 kilograms. But maybe that's reducing the weight too much, and therefore, if we go somewhere about midway, we're about 77.4. And so here in a little bit, when we talk about the creatinine clearance formulas, we're going to use a patient's weight and try to decide what is the most appropriate weight to use in the adjustment formula. But it's going to be to choose whether we should use actual body weight, ideal body weight, or adjusted body weight. And you can see how each of those body weights are calculated. So let's transition into the actual creatinine clearance formulas, but a little bit of background first. Why would you calculate a creatinine clearance? What is creatinine? So here's the deal. This all goes back to kidney function. What we are wanting to do is estimate a patient's kidney function. Why is that important? Because the kidneys play a very important role in eliminating drugs from the body. Remember how we talked in an earlier lecture how there's two phases when we take an oral drug. There's the absorption phase and then the elimination phase. And the kidneys play a huge role for many drugs. Maybe not every single drug, but most drugs have some component of their elimination of the body goes through the kidneys. The other big important organ that is involved in drug elimination is the liver. And again, it metabolizes, changes drugs to metabolites. Sometimes those metabolites are active or inactive, and so it changes the parent molecule. But the kidneys are often a huge role of actually then getting whatever's been metabolized out of the body. And so we won't talk about the liver anymore in this lecture. Let's focus on the kidneys function. Because what happens is, with age or disease or other conditions, the kidneys can lose their function. And the picture here on the top right shows you the various stages that can occur in chronic kidney disease. And we measure and we stage the degree of kidney disease by the percentage loss in normal function. Okay? Why that's important? Because as you start to lose more kidney function, the body becomes less able to, or slower to eliminate the drug. And if you don't change the rate in which you're dosing the drug or absorbing the drug, so if you're still absorbing and getting the same amount of drug in, but you reduce or slow the body's ability to get rid of the drug out, the drug levels in the body build up, and those drug levels can become toxic and cause all sorts of problems. So, what do we do in a patient who needs to be on a drug that is eliminated by their kidneys, but their kidneys aren't functioning as well? Well, we need to reduce the dose. Okay, and this is a big skill you'll get in pharmacy, and we'll show you an example here how to use your drug information skills to look up how to make this adjustment. But I want to make sure you understand in your mind there's two ways you can reduce a dose for somebody whose kidneys aren't functioning well enough to be able to safely eliminate the drug. You can either lower the individual dose. So, for example, if somebody's been taking 100 milligrams 3 times a day, instead of taking 100 milligrams 3 times a day, just take 75 milligrams 3 times a day. So clearly, that seems pretty obvious. Just reduce each individual dose. However, there are other alternatives. So what you could do is extend the dosing interval. So instead of taking 100 milligrams 3 times a day or every 8 hours, you can still take the 100 milligrams, but only take it every 12 hours or 2 times a day. So again, you can give the same dose each time, but you give it at a slower or a lower frequency, and therefore the total daily dose will go down. And there are some drugs, when we adjust them by renal function, where we do both of those things. So in this example, instead of giving 100 milligrams 3 times a day or every 8 hours, we would reduce the dose to 75, and we would also extend the dosing interval to every 12 hours or twice a day. So it's different combinations, and you don't need to just know what to do. You can't just look at a drug and say, oh, I'll do that. What you do is you look at that drug and say, oh, I need to pull that up in my drug information source, like Lexi Drugs. You pull the drug up, you look under the renal dosing section, and it gives you guidelines on how you should adjust that drug dose. So it's not like you just have to know what to do, but you should know what to expect that, well, this drug certainly is reduced or is eliminated by the kidneys. If kidney function is impaired, I need to look up to see how I would adjust that drug dose and then be able to know it. All right. So going forward. So we realize that to make these decisions about whether or not to change a drug dose based off of kidney function, we have to estimate the kidney function. And you can't just look at somebody and say, ooh, your kidneys aren't working very well. You can't do that. So how are we going to come up with a numeric expression that we can use to quantitatively decide whether or not their kidneys are functioning as good as they need to? So what we do is we calculate. We use formulas that have been derived from clinical studies that essentially would use a chemical that's produced normally on our body, and it's usually excreted from or produced by our muscle cells. So a normal muscle mass will produce a certain amount of creatinine. And that's just this chemical molecule. And it's just normally produced during metabolism in the muscles. Okay? It's put into the blood, and then the blood circulates in the kidneys, and then the kidneys filter and secrete and remove that chemical, this creatinine. Well, if the kidneys don't function as well, then the serum creatinine tends to build up, just like your drugs might build up. So we can use what happens to serum creatinine levels as a marker as to what would happen to drugs that are also removed by the kidneys. Okay? And so what we use is this creatinine and a formula that in the end uses creatinine to calculate what's called this creatinine clearance. And that's often abbreviated CrCl. And its units typically, we'll talk about one variation in a little bit, are in milliliters per minute. And that kind of freaks some student out, because what kind of units are that? What it represents is the volume of blood that the kidneys are able to basically process per unit of time in minutes. So in milliliters per minute, this represents the amount of filtration that can occur volume-wise per time. All right? All right, so the key marker we use to numerically come up with the creatinine clearance is the serum creatinine level. Okay, but don't get confused with serum creatinine and creatinine clearance. We use the serum creatinine, which is simply we take a certain amount of blood, we send it off to the clinical laboratory, and they measure the concentration of creatinine in the blood. And it has its own normal levels. And this is shown here kind of in the middle under normal values. Once again, it's made a little more complicated by the fact that females and males don't have exactly the same values. They're close, but not exactly the same. So, for example, females' normal ranges would be 0.5 to 1.1 milligrams per deciliter. Males are 0.6 to 1.2 milligrams per deciliter. All right? But that's the serum creatinine values. Those are concentrations in the blood. We use that along with other information, certainly including body weight that we'll talk about, into a formula that then calculates this creatinine clearance. And it has normal values based off of normal serum creatinine values. So a normal, typical creatinine clearance for a female, for example, would range from 88 to 128. But be careful with the units now. Once we put it in this formula, the units are now milliliters per minute. Or for males, a normal creatinine clearance might be 97 to anywhere up to 137 milliliters per minute. All right? All right, so now let's get, the whole point of the calculations class is to listen to me and look at all my funny kidney pictures. I love urine jokes, so you'll see some of those. But also the whole point was to practice using and calculating the formulas. The two that we're going to talk about in this lecture are the Jelliffe and the Cockcroft-Gault. All right, and you'll notice I put stars by the Cockcroft-Gault formula, as that is the one you will most commonly use in clinical practice. So I'll talk a little more about that later. But I do want to make sure, before I go into that between the Jelliffe and the Cockcroft-Gault formula, those aren't the only formulas by used. And to be honest with you, there's more and more, it seems like, developed every year. There are ones like the Schwartz formula, which is used. If you go to Children's Mercy, that's the formula you'd use more because it's more accurate in estimating renal function in pediatric patients. There are some formulas like the Salazar-Cochrane or the MD-RD that calculate it maybe more accurately in obese patients. And we'll talk maybe a little more about that. But so while these two, Jelliffe and Cockcroft-Gault, are common ones, they're certainly by no means the only ones. And that's why this is an entire area that you can spend a lot of time learning about, is how to estimate kidney function. We are just kind of scratching the surface. All right, having said that, we said one of the formulas that we will expect you to be able to calculate and get a number out of is the Jelliffe formula. And it's been used for a long time. And I'll be honest with you, it tends to be used more often actually in places like the ICU with acutely ill patients whose kidney functions are changing rapidly, meaning from day to day they have some really acute medical process going on, disease process going on, where the kidney function is not going to be stable from day to day to day. And so we would tend to use the Jelliffe formula because it's a little more sensitive in seeing those changes almost on a daily basis. Okay? So, having said that, let's just look at the formulas. Once again, you'll see with all of the renal formulas, they differ by gender. And there's usually kind of a key formula for males. Don't ask me why, but the main formula was derived off of males. And then there's an adjustment factor to get a correct value for females. So starting up above there, the creatinine clearance formula for a male using the Jelliffe formula is to take 98 and subtract from that the factor where you take the patient's age in years minus 20. So that difference, age minus 20, that value times 0.8, so 80% of that difference, that's what you subtract from 98. And then do not forget to then divide by the serum creatinine. And it's important here, the serum creatinine has to be, the number you use has to be expressed in milligrams per deciliter. So you have to use those units. If you do all of that, then you'll get a number, and that number's units would be in milliliters per minute, and it would represent their creatinine clearance. All right. The good news is for females, you do everything exactly the same that we just talked about, but we multiply the final value that we got for males by 0.9. So we only use about 90% of the number that we calculated for males would be the correct estimate for a female patient. All right? Pretty easy formula. There's only two variables here, age and serum creatinine, and both of those really don't have any clinical controversy. So the Jelliffe formula is really fairly straightforward. Unfortunately, it isn't the one that we use most often. The one that you're going to see most often referred to in your drug information sources, meaning when you pull up a drug and it says, okay, for this drug, you do need to adjust it based off of the creatinine clearance calculated by the Cockcroft-Gault formula. So this one is one you'll see most often referred to in your drug monographs as the formula to use for adjusting drug dosing. So you got to know it. This is also one I've been told that you really have to have memorized for the NAPLEX. So by the time you take your licensing exam after pharmacy school, you need to be able to just know the Cockcroft-Gault formula. It is just one that is used so commonly. Okay? So let's start with the formula. It's a little more complicated. It's got 3 variables versus the Jelliffe, which had 2 variables. But it's not difficult. You start with 140 and subtract the patient's age in years. So 140 minus their age. To that, you multiply by their body weight in kilograms. That value then you divide by the number 72 times the serum creatinine. So you don't just divide by the serum creatinine. And again, here the serum creatinine again has to be expressed in milligrams per deciliter, but you're going to take 72 times the serum creatinine, and that's what you divide the numerator with. Okay? Very much like the Jelliffe we talked about, that's the formula for males. To estimate for females, you do that exact same calculation, but you multiply the result now by 0.85. So unlike the 0.9 for the Jelliffe, for the Cockcroft-Gault, it's the 0.85 times the value for males to come up with the estimate for females. All right? Once again, it's a pretty easy formula if you think about it compared to other formulas you've probably had. The trick with this is, look on the formula again. You'll notice on the numerator, it's the 140 minus the age. That's not the problem. But you then multiply it by the body weight. And remember how we described how different a actual body weight is versus an ideal body weight versus an adjusted body weight. There's big ranges in body weight. So the point is, to get an accurate estimate using the Cockcroft-Gault formula, you have to use the most appropriate body weight. Okay? So down below is these are our clinical guidelines for you to use in this course, and then we'll have you use in lab, but you might see variations in practice. But what we think the most accurate way to use the Cockcroft-Gault formula is to do this, is to decide which way to use between actual, ideal, and adjusted. So what this says on this slide is if the actual body weight of a patient is actually less than the ideal body weight that you calculated for them, then you would use their actual body weight. This is in the case where somebody's body weight, normally for them, not a disease or a body weight that's happened due to lack of, some sort of disease process. If their actual body weight is just normally very thin and they normally run it less than what you would calculate for their ideal body weight, then you use their actual body weight. That's their normal body weight. And it obviously does not have a lot of extra fat on it, so let's just use their actual body weight. What happens if their actual body weight is above their ideal body weight, but less than 125% over ideal body weight? And here's what we're drawing a line. We're drawing a line in the sand. We're saying that if you're more than 125% over your ideal body weight, then that's getting into a degree of obesity, a degree of extra adipose tissue that could inaccurately affect our calculation for the creatinine clearance. Okay, so If you're between ideal and 125% of ideal, if your body weight is somewhere between there, then you're in a healthy range in this sense. So we would actually just use the ideal body weight. You're close enough to your ideal body weight that we'll just use the ideal body weight. So ideal body weight to 125% of ideal body weight. If your actual body weight is somewhere in that range, then we use ideal body weight. If your actual body weight is greater than 125% of ideal body weight, that is, there is this excess adipose tissue, then we would use the adjusted body weight. Okay? So all of this sounds confusing even listening to myself. The point being is, before you just plug a weight in the Cockcroft-Gault formula, you need to think about the weight. The weight to use would be the actual body weight if their actual body weight is less than ideal, or you use the ideal body weight when their actual body weight is between their ideal and 125% of ideal, or you use the adjusted body weight in the formula if their actual body weight is greater than 125% of their ideal body weight. That summarizes the kind of thought process that you have to use. If nothing else at this point, just remember the Cockcroft-Gault formula is a very important one to memorize. You need to know how to use it and use it correctly, but think about which weight to use in the body weight part to it. That, because using the wrong weight there can make this estimate inaccurate. Well, let's just do it. Let's use these formulas in an example here. So the question reads, determine the creatinine clearance rate for a 70-year-old female patient who weighs 190 pounds and stands 5 feet 7 inches tall and has a serum creatinine value of 1.6 milligrams per deciliter. And we're going to do this with both the Jelliffe and the Cockcroft-Gault formula. Okay? So before we use those formulas, let's think about the patient's weight. All right, so we said this patient's actual body weight was 190 pounds. So let's convert that to kilograms. So we take 190 times the fact that there's 1 kilogram over 2.2 pounds. Pounds cancel. And we see that this patient actually weighs 86.4 kilograms. All right, easy. Let's calculate her ideal body weight. We would use the formula that says to take 45.5 kilograms plus 2.3 times each inch over 5 foot. She's 5 foot 7, so we'll take 7. So if we have 2.3 times 7 plus 45.5, that should equal 61.6 kilograms. All right, so that is her ideal body weight. The next step now is to actually calculate her actual body weight as a percent of her ideal body weight. Okay, so that's easy. Let's just take her actual body weight, which we said was 86.4, and we're going to divide it by her ideal, which was 61.6, and then we multiply by 100 just to express it as a percent, and we can see that she weighs 140%. Her actual body weight is 140% of her ideal body weight. That's above 125%, so that extra weight is a degree of obesity. And so we're not comfortable using her actual body weight to use in our formulas, but her ideal body weight is too low as well. So let's calculate her adjusted body weight. Since she's greater than 125%, we're going to want to use an adjusted body weight, so let's calculate that. That's easy. We take the ideal body weight we've already calculated at 61.6, and to that we're going to add the difference between her actual and ideal. So we're going to take 86.4, her actual, minus the 61.6. So whatever that difference is, we're going to multiply that difference by 0.4, and that's what we add to the 61.6. So if you do that math, you can see that her adjusted body weight is 71.5 kilograms. So that's the weight we would use in the Cockcroft-Gault formula. So now let's start using the formulas. If we start with the Jelliffe, you can see that's a much more straightforward formula to use. For a female, or we'll start on top, we'll use the male creatinine clearance formula for Jelliffe, is to take 98 minus, remember it was the age minus 20, so her age was 74 minus 20, and we multiply that difference by 0.8 and divide it by the serum creatinine, which was 1.6 in milligrams per deciliter. So you do that math and you get 34.3 milliliters per minute. But keep in mind that was the formula for the male. So to adjust it for a female patient, you take that value, 34.3 times 0.9. And so this patient's final calculated creatinine clearance using Jelliffe formula would be 30.9 milliliters per minute. Okay? Now, let's do the same thing, but using the different formulas. Use the Cockcroft-Gault formula. So we'd use 140 minus their age, which was 74, times, and remember we chose to use their adjusted body weight because she was over 125% over her actual was 125, more than 125% over her ideal. So we're using the adjusted body weight of 71.5 kilograms. Divide that by the number 72 times the serum creatinine of 1.6. So we do all that math, and you should get 41 milliliters per minute. Remember, that was the male formula, so to adjust it for the female, we take that value times 0.85. And for this patient, we would see using the Cockcroft-Gault formula, the value is 34.9 milliliters per minute. So if we compare those values, the Jelliffe was 30.9 and the Cockcroft-Gault was 34.9. They're close, but they're not exact. So different formulas don't give you exactly the same values. And certainly with the Cockcroft-Gault formula, different weights in the formula will give you very different values. So that's why you need to try to get as reasonable estimate as possible. It's important to always try to make sure you're using the most appropriate formula and the most appropriate weight in that formula. And so that part of that is important. Okay. Well, we need to add one other level of complexity to this, being able to determine as accurate an estimate of kidney or renal function as possible. And up to this point, we've already talked about how the body weight in these formulas makes a big difference. And again, that's because creatinine comes from muscle, not from fat. Therefore, if you want to really estimate using creatinine, you need to use a muscle mass, not a fat mass. So we went through that whole thing about body weight. Sorry to make you relive it again, but it's important. But now we got to go beyond that. So assuming even now we have the right body weight and we use that into our formula. So what I'm going to talk about here doesn't affect the actual calculation of the creatinine clearance up to this point. And remember, the units up to this point were in milliliters per minute. So if we correctly use the right body weight in the correct formula, we get a reasonable estimate of creatinine clearance in milliliters per minute. Okay? The other complexity we need to add in is the fact that the kidney function is proportional. The functioning of the kidney is proportional to the kidney size. The larger the kidney, the more nephrons, the physically larger the nephrons are, the more blood they can filter, the more function the kidney can have. All right? So bigger kidneys have more function, and guess what? Bigger people in terms of body surface area, physically taller, wider, not obesity, we're not talking about fat, but physical shape and size of the body. If somebody's got a larger body, they have a larger kidney, and that inherently gives them greater kidney function. That doesn't mean their kidneys are more healthy necessarily, but when their kidneys are healthy, they can function more than somebody else's kidneys that are healthy, okay, if they're a smaller person. So we just need to know that we may need to actually change the estimate of how well the kidneys are functioning based off of their actual physical size. And we would use the fact that the kidney size is proportional to body surface area. So we've already calculated body surface area. We've done those formulas. And I'll remind you, they correlated both weight to height to be able to determine a body surface area. So what we're talking about doing here is taking a creatinine clearance and adjusting it for body surface area. BSA, adjusted creatinine clearance, is simply this. Take the creatinine clearance you've already calculated, doing everything we've already talked about with our formulas, and simply multiplying it by the patient's body surface area divided by a standard normal value for young adults, which is 1.73 meters squared. That's kind of this magic number we always compare body surface area to, because that is a normal value for a young adult, okay, of average weight and average height, and average body surface area would be 1.73. So by taking the patient's body surface area, and let's just say they're completely average normal person, and their calculated body surface area is 1.73. Well, that's the same as this average. 1.73 divided by 1.73 would be 1. So we essentially wouldn't adjust the creatinine clearance. But let's just say this patient is super tall, okay? And so when we calculate their body surface area is 2.5. Well, 2.5 divided by 1.73 is still going to be a value greater than 1, and therefore it's going to proportionally increase the calculated creatinine clearance. They'd have a larger function. Let's say this person is really fairly short and has a fairly low body weight and has a body surface area of 1.3. Well, 1.3 divided by 1.73 is going to be a value less than 1, so we're going to be proportionally making their calculated creatinine clearance smaller in the end. So what we're doing is taking the function we calculate with these formulas and adjusting it either up or down proportionally to how close they are in body surface area to our normal average person of 1.73. Okay? Now, and this is becoming more common because this is in some ways a more accurate estimate of renal function. It's not only using their weight and age and creatinine values, but also now factoring body surface area. It's one more factor that could be used to truly tweak and get a more accurate value. When would you know that you have to do this, and you're going to see this in this last example here, is if your drug literature sources say that you need to adjust a drug dose based off of these levels of renal function. If they give those levels of renal function in milliliters per minute per 1.73 meters squared, if you see that additional unit of 1.73 meters squared in the value, then you know you have to adjust the body surface area. So, and that is now being reported for more and more drugs. So we're having to do this additional step. So let's just go through this. It says, there's a question. Determine a body surface area adjusted creatinine clearance rate for a 70-year-old female patient weighing 190 pounds and standing 5 feet 7 inches in height and having a serum creatinine of 1.6 milligrams per deciliter using the Cockcroft-Gault equation. Okay, this is very similar to what we've already done, obviously, but now we're going to factor in the body surface area. So the first thing we have to do is calculate the body surface area. I'm going to do this quickly since we have done this before. This patient is 5 feet 7 inches, so 5 feet times 12 inches per foot gives us 60 inches, plus the additional 7 inches gives us 67 inches. 67 inches times 2.54 centimeters per inch gives us 170 centimeters. We take her weight, 190 pounds divided by 2.2 gives us 86.4 kilograms. Now we can use the body surface formula, which takes their height of 170 centimeters times their actual body weight of 86.4 kilograms. Multiply those, divide that by 3,600, take the square root, and we see that this patient's body surface area is 2.02 meters squared. So what we would do is take her creatinine clearance that we've previously calculated on the previous slides. We said for her was 34.9 using the Cockcroft-Gault formula, and it's 34.9 milliliters per minute. Now we multiply it by the value of her BSA of 2.02 divided by 1.73, and we see that our final value would be 40.8 milliliters per minute, which is larger than, kind of significantly larger than what we had just calculated on the creatinine clearance alone. But that should make sense because look at her body surface area is 2 compared to 1.73. So again, her larger size, body surface-wise, means that the calculated creatinine clearance, we need to account for a physically larger kidney. Therefore, a more reasonable estimate would be the 40.8 milliliters per minute. And that's this idea of actually using the formulas that we've already had and adjusting the final value and standardizing it per a 1.73 meters squared individual. All right, so this is the last thing. Let's tie this all together. I wanted to give you kind of a more realistic clinical example of the drug references you would use and why you would go through and do this sort of calculations with creatinine clearance. It's a very important skill. So let's go through the question. It says, what would be the dose and frequency of the antibiotic ceftazidime for an 84-year-old male patient weighing 143 pounds and measuring 66 inches in height? They also have a serum creatinine value of 4.22 milligrams per deciliter. And to do this, we're going to look up. So let's look up. Do we even have to adjust? We could calculate a creatinine clearance, but why adjust it if the drug, and not all drugs do need to be adjusted based off of kidney function. So let's pull up ceftazidime. So on the left-hand side, what I'm showing you is we used LexiComp or LexiDrugs online. We pulled up the website. We typed in ceftazidime. We pulled up the drug monograph. And on the left-hand side, we went under dosing. And this drug, ceftazidime, had a special section for dosing called renal impairment for adults. I clicked on that, and on the right-hand side, you can see exactly what it said. It said, renal function may be estimated using the Cockcroft-Gault formula, and then it gives me ranges for those results. So if the Cockcroft-Gault formula value is anywhere from 31 to 50 milliliters per minute, the dose is 1 gram every 12 hours. However, if the function is reduced to 16 to 30 milliliters per minute, keep in mind, those lower values mean lower kidney function. And remember how I mentioned how we would therefore want to give a lower dose? Well, notice this for ceftazidime, we're giving the same dose at this point. It's still 1 gram, but we would reduce it to every 24 hours. All right. Let's say the kidney function is even worse than that. Let's say it's only 6 to 15 milliliters per minute. Then you'll notice we do both things. We reduce the dose from 1 gram to 500 milligrams. And we also reduce the frequency, again, from 12 hours down to the 24 hours. And if it's even worse than that, if the creatinine clearance is less than 5, which is almost no kidney function, that's bad, then the value would be 500 milligrams extended to every 48 hours. And I like this as a good example to show you that for this drug, depending on the degree of renal function, we are absolutely going to either lower the dose, extend the interval, or do both, lower the dose and extend the interval. These are all the permutations that might need to be done. So to know what the correct dose for this patient for ceftazidime would be, we're going to have to estimate their renal function. So let's do that. The first step is to, since we're going to be using the Cockcroft-Gault formula, we must decide which body weight to use. So let's do this quickly. Their actual body weight was 143 pounds. We divide that by 2.2 to cancel pounds to get kilograms, and we see this patient actually weighs, their actual body weight, 65 kilograms. Let's calculate their ideal body weight. 50 kilograms for a male plus 2.3 times each inch over 5 feet. This patient is 66 inches. So again, 5 feet is 60 inches. So they are 6 inches over 5 feet. So 6 times 2.3 plus 50 gives us 63.8 kilograms. So now let's calculate how much over their ideal body weight their actual body weight is. So take their actual body weight of 65 divided by their ideal of 63.8 kilograms times 100, we see this patient has 102%. Their actual body weight is 102% of their ideal body weight. Well, that's great. That's a very normal weight person. They're very close to their ideal body weight. They're certainly not less than their ideal body weight, but nor are they greater than 125% of the body weight, so they're certainly not obese. So they're 102%. That's between 100 and 125%, which means we will just use their ideal body weight for the Cockcroft-Gault formula. Now that we've made that decision, we can actually just use the formula to calculate this patient's creatinine clearance. The formula would be, for a male patient, 140 minus their age, which was 84, times their ideal body weight, which was 63.8, divided by the number 72 times their serum creatinine in milligrams per deciliter, which was 4.22. You do all of that math, you get 11.8 milliliters per minute. Okay, so let's take that value and compare it back to the drug information. Now, at this point, you're saying, well, do we need to adjust for body surface area? And I would argue, for this drug, no, because the instructions for how to adjust the dose are given to you in units of milliliter per minute. It does not factor in the 1.73 meters squared. So I don't need to go to that additional step. I can use the drug information the way it is with just the milliliters per minute. Since our value is 11.8, we would drop down to the third level where it says creatinine clearances between 6 to 15 would be 500 milligrams every 24 hours. So what you would do is inform the doctor and say, doctor, I recommend starting this patient at ceftazidime 500 milligrams every 24 hours. Since this is the dose recommended by LexiComp, adjusted for his creatinine clearance of 11.8 milliliters per minute. And there you've had it. You've made your first clinical recommendation for adjusting a patient's dose based off of their renal function. It's really cool, and this is definitely an important role that a lot of hospital pharmacists have. Every day they go into work, they run off the renal dosing reports, they pull up the most recent creatinine clearances, and they check safety to make sure that all the patients are on the correct dose based off of their renal function, and now you know how to do it. So hopefully you found this lecture helpful.